it on? Yeah? It doesn't sound. Does it sound? Oh, okay. 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 We're going to get started. Good afternoon, everybody. Thanks for coming to this afternoon session. Oh, I thought he was talking to me. Mm-hmm. Okay. No, I thought he was talking to me. We're going to be covering the child contact management cascade, and we're going to be closer? Oh, sorry. Okay. We're going to be discussing barriers and facilitators to child contact management, as well as discuss some strategies that countries are currently using. And we hope that this will be a good discussion that will help improve implementation of the cascade. So Daria Swarko will start us off with child contact management in high TB burden countries. Oh, you can use that. Just go that.
All right. Hi, everybody. Thank you so much for coming. I'm very happy to be here today to present our systematic review on child contact management in high burden countries. I have nothing to disclose. So just for some background, as many of you know, children under 15 years contribute approximately 10 to 20% of the disease burden in TB endemic areas. And disease progression in children is higher than in adults, particularly in younger children under 5 years. And young children with active TB disease are at great risk of progressing to severe disease and death. And fortunately, we have preventive therapy that is a tool available to us, and isoniazid preventive therapy has been shown to decrease this progression to disease by 59%. So when did this child contact management conversation really begin? It started in 2006 when the World Health Organization came out with guidelines that urged national TB control programs to conduct contact investigations and offer IPT to child contacts under 5 years and HIV-positive contacts of any age. And I think that this algorithm is likely familiar to many of you. Now fast forward to 2016, when the WHO Global TB Report came out and incorporated for the first time measures of rates of IPT initiation in child contacts under 5 years. And they set a target goal of 90% for IPT initiation. Out of the countries, the 47% of countries that had data, and unfortunately only 9 of the 30 high burden countries were able to report, only 7.1% of eligible child contacts initiated IPT. This is much lower than the 90% target goal. And one of the reasons for this is probably that, we're talking about IPT initiation, but really the story is much larger than that. And it really begins by a discussion of the entire child contact management cascade. And it doesn't start at IPT initiation. This process actually starts with identifying these children, then bringing these children in for screening to rule out active TB disease. And then those that are found not to have disease, we need to then initiate IPT and then follow that up with the ultimate goal of completing IPT. And of course, now when we look at this entire cascade, there are losses at each of these steps. So losses at identification, losses at screening, losses at initiation, and losses at completion. And so you can see that this process is much more complex than just IPT initiation. And so we set out to do a systematic review to apply this cascade to child contact management and then report on the child contact losses at each of these steps. And we also really wanted to summarize the common challenges, the implementation gaps, and the predictors of outcomes among child contact management programs around the world. We also wanted to identify strategies that may be useful to programs at each step or at all of the steps in the cascade. And then ultimately, we hoped to provide some guidance to national TB programs as well as individuals who are conducting child contact management to be able to improve their programs. So we searched 3 databases, PubMed, Scopus, and Web of Science. We looked at studies that were published between 1996 and 2017. We chose this date range because we were trying to get 10 years pre and post the WHO 2006 guidelines. And then we included child contacts who are household contacts under the 15 years from programmatic settings in high-burden countries, which we defined as a TB incidence of greater than 100 per 100,000. And we were looking for papers that introduced some CCM strategies that were targeting aspects of the CCM cascade. We were looking for any quantitative, qualitative, mixed method study design, except for randomized control trials, editorials, or commentaries. And we also excluded IPT in HIV-infected children, MDR child contact management, as well as hospital-based programs such as neonatal prophylaxis, because the logistics and infrastructure for these programs was very different from routine child contact management. And in terms of the articles that we included, we started with 1,919 studies that we screened through titles and abstracts. And then we were left with, wow, I can't even read that on the screen. Hold on a second. We were left with 88 full-text articles that we reviewed, and then finally included 37 studies for the systematic review. 22 of these studies were in the Africa region, 14 were in the Southeast Asia region, and 1 was in the region of the Americas from Peru. And if we look at the number of CCM studies published per year, so there were none published between 1996 and 2001. There were 6 studies published between 2002 and 2006, and then once the WHO guidelines hit, 31 studies were published to date after that. We included 25 quantitative studies, 3 qualitative studies, and 9 mixed method studies. Now, this is a presentation of the quantitative results of the proportions of child contacts completing each step of the cascade. And for this, there were 34 studies that included quantitative data. In these studies, the sample size ranged from 24 to 1,227 child contacts. And now, so the range of proportions for child contacts completing screening ranged from 2.7 to 100%. For initiation, this range was 2.3 to 100%. And for completion, 0 to 100%. So you can see that there is a great range throughout the world in child contact management, and not a great representation of how we're doing. Now, another way to look at this is, let's consider the studies reporting less than 50% of cascade step completion. So out of the 17 studies that had screening data, 41% of them had less than 50% cascade step completion. When we look at the studies that incorporated initiation data, 38% of them had less than 50% cascade step completion. And then finally, for completion of therapy, 59% of our studies that had data reported less than 50% cascade step completion. So the next step for us was to go through all of these articles and identify challenges and recommendations that were brought up by the authors. And then what we did with that information is we went through and we actually categorized these challenges and recommendations into broad themes. And so you can see we have 7 challenges that were identified and 3 recommendations that were identified. And I'm going to go through each of them. So the first challenge involves health system infrastructure, and this includes 3 subcategories. The first is government and NTP prioritization. It was included in 6 studies. Lack of documentation tools was a challenge that was discussed in 13 studies. And then 9 studies discussed limited staff resources to be a challenge. And just to give you an example, so this is a study from Ethiopia. Healthcare workers did not remember how many children they had screened, as they do not keep records. Only 2 out of 60 healthcare workers could show their records of children on IPT in the last quarter. I think I need to change my contacts because I'm having trouble reading that screen. The second challenge involves knowledge gaps, and that was really broken down into 2 main categories. So index case and caregiver knowledge, and then healthcare worker knowledge. And then healthcare workers also had trouble with TB diagnosis, and then also their knowledge of INH resistance in IPT. An example of this is a healthcare worker from Indonesia. My understanding of IPT is limited. As far as I remember, there is no guideline for IPT available in Puskesmas. I have no confidence to explain IPT to the patient. Attitudes and perceptions is the third challenge. This is broken down to two subcategories. Risk perception, 17 studies discussed that index cases and caregivers who had healthy and asymptomatic children did not feel that that child needed to be on IPT. And then 2 studies discussed patient-provider relationships to be a challenge. And then an example here from Ethiopia again, 67% of parents whose children had very poor compliance indicated the main reason for noncompliance was the perception that drugs were not necessary when the child was healthy. The fourth challenge is access to care, and this includes 3 subcategories. Cost is the first, and it was discussed in 11 studies. And this is cost including transport, screening, diagnostic testing, and treatment. The second is travel time and coordination. This was discussed in 10 studies. And then wait times and clinic schedules were a challenge in 5 studies. And to give you an example from South Africa, however, access was a problem for people with limited mobility or those employed full-time, as the clinics were not open during weekend and public holidays. The next challenge was competing priorities, and this relates to family priorities. So index cases and caregivers were prioritizing their own work schedules or their own health over the child contacts. Finally, the sixth challenge is treatment related. So this is medication, so the size, taste, duration of treatment was discussed in 5 studies. Experiencing side effects was a problem in 3 studies. Ability to administer treatment to the child was discussed in 4 studies, and procurement of INH was an issue in 4 studies. And this is a mom from Indonesia. My child always cries about the bitter taste of the medicine, and I always needed someone else to help me make her take it. And then finally, stigma. So stigma-related challenges were discussed in 5 studies, and so the idea that if a child contact is on IPT, this will bring stigma from family and community members. So after we went through the challenges, we also categorized the recommendations, and there were 3 themes that came out of this. They were health system strengthening, health education, and improving preventive therapy. So for health system strengthening, there were 2 subcategories. So 14 studies mentioned that monitoring and evaluation tools are needed, and that prioritizing child contact management, supporting healthcare workers and clinics was very important in 19 studies. And some examples of this, doing quarterly supervisory visits with routine measurement of child contact management progress, coordinating with agencies like daycare centers or schools, and considering DOT for the first few months of treatment to possibly improve adherence. The next recommendation is for health education, and again, this is the subcategories of index cases and healthcare worker education, and discussed in many studies, so 22 for healthcare worker education and 19 for index cases. And some recommendations made were having continuous health education with the family throughout the 6 months of IPT, targeted messages and educational materials to improve family awareness of child contact screening, and addressing incorrect perceptions that asymptomatic contacts do not need IPT. And then finally, the last recommendation was improving preventive therapy itself. And so we can see that shorter regimens were recommended, syncing the index case and child contact visits, ensuring availability of IPT, and then, of course, child-friendly formulations. And the last results we wanted to share with you were the predictors of child contact management cascade steps. And 11 studies incorporated a predictor analysis. And I'm actually going to move over here. Can you guys hear me okay? Can you turn this mic on? It's okay. Hello? Hello? So I separated this into index case characteristics and child contact characteristics. And so if the index case was a parent, or if the index case reported sharing a bedroom, these two characteristics were associated with increased screening and IPT initiation. And then if the index case was a female, index case had high perception of child contact susceptible to disease. The index case had low perception of barriers to treatment, or if the index case had serious intention to bring the child in for screening, those were all factors that were associated with increased screening. If the index case agreed that IPT should be given to well children, this was associated with increased IPT initiation. And then distance was also a factor. So if children were living closer, or families were living closer, then they were more likely to be screened and initiate IPT. If the child contact was identified at an urban clinic rather than a rural clinic, this was associated with increased screening. But interestingly, down here you can see that initiating therapy at a rural site was actually associated with higher completion. And perhaps this is because of relationships between healthcare workers and patients in the rural setting compared to the urban setting. And then low medication costs, low transport costs, shorter regimens, and directly observed therapy by healthcare worker community supporters were all associated with increased completion. Now, one thing to note, this list is not exhaustive. This is limited by what the authors decided to study, and so many of you probably have predictors in mind that should be on this list. And also, these blank areas here do not represent that there was no association. It means that they weren't actually studied. So, just to summarize, there are many losses at each step: identification, screening, preventive therapy initiation, and preventive therapy completion. And we saw great variations in the rates of TB identification and as well as the other steps of the cascade. Now, I know this is a very busy slide, but I put it here because it's in our systematic review, and so I wanted you guys to be aware of it. What we did here is we created a driver diagram where we took the challenges, the recommendations, as well as our predictors, and we created a figure to hopefully provide some guidance to national TB programs as well as individuals conducting child contact management on all of the barriers that go into CCM. And then we also used the articles that we read to incorporate possible interventions on tackling those strategies. There may be many more interventions that are setting specific, but this might be a good place to start. So what are the implications? Really, the implication of this review is targeting Pillar 1 of the NTB strategy. And as some of you may know, Pillar 1 really urges us to put the patient at the center of health service delivery. And it encourages us to integrate patient-centered TB care and prevention. And so really what we need is a robust paradigm shift towards prevention and family-based TB care so that we can have equitable distribution of resources and have a child contact management friendly healthcare environment. Other implications, I think that this review demonstrates the many factors related to successful delivery of preventive therapy among child contacts, and it's not just about IPT initiation, it's about the entire child contact management cascade. And really this leads us to believe that perhaps a standardized guideline is needed for an effective CCM strategy. And from the systematic review, we believe that this should incorporate an active strategy to identify contacts at risk, whether that's in the clinic, having better tools and registers, or if it's in the community and doing household visits to identify these contacts. Having the structure, processes, and tools in facilities and community to implement and monitor child contact management. Ongoing training and education for healthcare workers tasked with implementing child contact management, as well as tools and strategies to educate our caregivers and index patients and the community as a whole. And finally, we need more research toward improved, shorter, and child-friendly preventive therapy treatment regimens. So in terms of next steps and things that you can do, so when we do future studies, we should really work to uniformly report on child contact management cascade steps. So for example, reporting number of child contacts screened rather than reporting the number of index cases bringing child contacts in. This will help us be able to work together and really understand the barriers in each other's settings. There's definitely room for systematic reviews in MDR child contact management, as well as strategies for IPT delivery in HIV-infected children. You'll remember that we left these populations out, and so it would be great if someone could take that on to be able to make recommendations for those areas. And then considering 1/3 of our studies were actually from South Africa, more studies are definitely needed from other countries. And as you walk around this conference, I think we can all appreciate the many presentations that are taking place regarding child contact management. And hopefully everyone will go ahead and publish that work so that we are able to learn from each other, improve our child contact management strategies, increase IPT initiation, and ultimately decrease the burden of TB disease in this vulnerable population. Thank you.
We have time for some questions. If anybody, there's no microphone. Oh, okay, right. There's a microphone.
I'm wondering if in those studies there was some stratification as to contacts with smear negative culture positive versus smear positive culture positive. I didn't hear you say that if you did.
So from my memory, there was probably only 1 or 2 studies that included information regarding smear negative and smear positive, but for the most part, these were contacts of bacteriologically positive index cases.
And does anybody calculate whether or not the rate of treatment of latent infection speeds the rate of decline? Sorry, it's just a question.
That's a great question. Not that we found, but I think that would be an excellent thing to take on. What? Sorry? Any other questions? Great. So next I'm going to introduce Yael Hirsch-Moverman, who's going to be talking about her work in Lesotho.
Will the slides come up? Okay. So I'm going to be sharing with you today some results from a very small pilot study that we conducted in Lesotho, where we tried to begin to look at preventive treatment preferences among caregivers of child TB contacts. Oh, sorry. Which one is it? Okay, I'll figure it out. Oh, I have no conflict of interest. So I'm going to be discussing a little bit background and context in Lesotho, and then sharing some results from the pilot studies, and then suggesting some next steps. So the Kingdom of Lesotho is a very mountainous country, and it's landlocked completely by South Africa. The population is about 2.1 million people, and about 57% live below the poverty line. And life expectancy is very low at 56 years. And HIV prevalence among adults 15 to 59 years of age is 25.6, second only to Swaziland. Lesotho has the second highest TB incidence in the world, estimated at 788 per 100,000. And almost 3/4 of the TB patients are co-infected with HIV. And TB is the most common cause of death in people with HIV. In terms of pediatric TB, in 2015, there were 5.5% of TB cases in children under 15 years, and we know that we generally expect about 10 to 20% of cases to be in children, so very low. The National TB Program in Lesotho recommends what the WHO guidelines stipulate, the screening of all household contacts, and providing IPT. And the MOH is definitely committed to efforts to implement guidelines and to controlling TB among children. And we all know that a new diagnosis of TB infection or disease in a young child reflects recent transmission. And we also know that TB in children is preventable. We know that identifying and screening contacts of TB cases is effective. We know that IPT has been shown to be effective in children. We know that screening and provision of IPT in young children is highly cost effective, and it is recommended by the WHO. But IPT is really underutilized, unfortunately. So globally, there were 1.2 million child contacts that were eligible for preventive treatment in 2015, but as Daria already mentioned, only 7.1% of eligible children actually initiated IPT. And we now have alternative, shorter regimens for preventive treatment that have been shown to be efficacious and safe. And they include 3 to 4 months of daily isoniazid and rifampicin, 3 to 4 months of daily rifampicin, or 3 months of weekly isoniazid and rifapentine. And these regimens have been used in children in low TB burden countries, but they are not widely used yet in high burden settings. And we think that implementing these shorter regimens can potentially improve adherence and also get more children into treatment. We also think that patient preferences are an important part of decision making. And traditionally, these patients' involvement in treatment decision-making has been really limited, both in terms of informing the planning and development of healthcare services, as well as one-on-one patient-provider communication. Understanding patients' preferences it can be really critical, and we know very little about patient, and in this case we mean children's, preferences regarding preventive treatment, and so caregivers really, since they're the one responsible for getting the children to take the medicine, and ensuring they actually adhere to the treatment. And so it's important to understand caregivers' beliefs about preventive treatment, as they can really affect the treatment outcomes. So basically, because high TB burden countries are beginning to consider using these regimens, and some have started, and you'll hear some more about it later, we feel that it's important to understand what regimen attributes are important to caregivers, what regimen is preferred by the caregivers if they were offered a choice, and the reasons behind these preferences. So what we did is we set out in a very small pilot study to ascertain preferences of caregivers regarding TB preventive treatment regimens in eligible children in a high TB burden country. So what we did is we conducted 12 in-depth interviews with caregivers of child contacts who completed IPT at 5 health facilities in one district, the Berea district in Lesotho, and you can see here on top left, that's the country of Lesotho, and that's the one district, and we included 5 sites, 3 of them were urban sites and 2 of them were rural sites. And our interview guide had included 3 sections. First, we explored what are important factors that, for caregivers when they make a treatment decision for their children. After that, we assessed their interest in actually sharing the medical decision. And third, we presented them the different treatment regimens and got their feedback on it. So what we told them were 6 months of daily isoniazid, 4 months of daily rifampicin, 3 months of daily INH and rifampin, and then 3 months of weekly isoniazid and rifapentine. So these are our 12 participants. The mean age was 35, and we had 11 out of the 12 were female. And in terms of education, half completed or had less than primary school. Only one person was employed, and the caregiver was the index case 4 out of the 12. And two caregivers reported adherence issues for their children. So the most cited factor that caregivers mentioned was pill burden, and that included the number of pills and the size of the pills. So here's a quote. Pills are not like syrup. Child is very sensitive to some things. She does not have the understanding of why some things are important to use. The length of taking the pills, I don't have a problem with that as long as it's the quantity taken per day is right for someone that age. And that's a father that said that. This mother said, just because he's a child, I think it could be a small pill. It should be 1 or 2 pills. And this came up a lot in the interviews. Another important factor was treatment duration and treatment frequency. This mother said, it's very important, ma'am, very much as to how long the child will drink it. And another said, I feel it's very important to be considered the number of times that they shall be used. Provider recommendations of treatment was also viewed as quite important. And this mother said, I think she, the nurse, cannot give me something which is wrong, and she knows better. Side effects came up as well, but it wasn't so much about having the side effects as being aware of them before they might happen. So this mother said that thing of considering the side effects is important, because if you're not knowledgeable about the side effect, that's when you see that there's a problem with, and you'll be scared and think of stopping the medication because your child is like this. We then asked caregivers about sharing the decision making, and most of them expressed an interest in sharing the treatment decisions, although many of them said that they will yield to the provider. And I put up this long quote, but I think it's very, very telling. I would like to be involved in the decision making because the sick child is mine. They should tell me what to do this, and we should be in agreement, because they will be advising and I'm the one to make the decision as a parent. And because they can give me medicines, but when I get home, I can put it aside, which I think is what a lot of patients actually do. Where was I? And not continue with them. The service provider would be having the understanding that I have given her child's treatment, which when I get home, I would be saying, they are burdening my child with medications, etc. And then I put them aside and I couldn't take action. This means that I am the one who makes the decision. I think this is a really, really telling quote of what our patients, or caregivers in this case, do with our treatments. This one is a quote from an aunt. So she's the caregiver, but not the direct decision maker. And she said that decision should be a joint one made for all those people, because when I have brought the child here to the health center, I am the one who meets the nurse, who explains to me in the absence of the family. When we have reached a common decision, I will go home to explain to them how the medication works. I would not refuse to take the child's medication and say, I'm going to ask those at home if I should take the medication, while already I see the need for the child to take the medication. I will explain to them when I get home and show them the importance of the medication. But a few of the caregivers were not interested at all in the shared decision-making, and they just preferred to have the provider decide for them. This mother said, I think the nurse is the one who knows everything, which is being discussed about the child's medication, because as for me, I don't know anything. And another mother said, I don't know anything about medication. If I'm only told that the child should take medication, and if I am told by the person who qualifies for that, because it can be difficult for me to make a decision. So not everybody's interested. When we got to the treatment preferences section, many of the participants, I think most of them actually, wanted to make sure that all the treatments were equally effective before they even expressed any preference about anything. Like this person said, would the child still be safe when he has taken these two that I've given her daily? So these are experienced IPT users, so they're comparing to IPT. So 4 months of rifampin generated a lot of interest, and those that preferred 4 months of rifampin were especially interested because of the pill burden. So this father said, I like it because if there's something wrong or something good, you can see it immediately because if it's taken daily, it is taken daily. So he's comparing to the weekly regimen, right? So he was concerned that if it's the weekly INH rifampin, you get a side effect, you don't see it right away. Whereas if it's daily, you know right away. Oh, wait. Okay, sorry, pressed the wrong button. And then this mother said, you know, it's just one tablet. The other ones, they're just too many, you know. And another said, because one is taken once, a child can give problem at times. I'm able to cheat him with that one. I choose to give him only one. So again, this ties into the pill burden that was a big factor that people talked about. The choice of the weekly dosing of INH and rifampin was tied to the treatment duration and also the frequency. And it was generally thought that shorter is better, but there was a lot of concern about weekly dosing. And I think this is a good illustration. This mother said, the one which is taken once a week, I would choose that one for her. I have realized that children are not the same as us. It is difficult to give her children medication. They give problem when you give the medication. So this one actually, because it's so hard for her to give the medication, she's like, I just want to do it once a week. But lots of people who were very attracted to this regimen later on said, yeah, but I'd rather do it daily because I'll forget once a week. And then this mother said, I think the one which you take once a week for 3 months so that I don't forget them. So six months of INH, people know about it, they trust it, they've heard about it for a long time. This person said, I would choose the one that I already know, the one that I know. I've already observed that it treats them. I have observed that it's right for them. I trust it. So I will not go for the types that I found not know, the new ones. So our study had some limitations. It was a very small pilot study, and participants were experienced users of IPT. So this is an example, a quote that from a mother who said, now that he has already taken a lengthy treatment, when he takes it again, so she thought we were asking if he had to take it again, since I see that he's healthy, he could take the one of the three. I also want to think that they are not only three for nothing. They are doing something. So she's basically saying that because her kid already took IPT, now he can take a shorter regimen. So that's a flaw of the study because they already took IPT. The other thing is that we did not account for fixed combinations of INH and rifampin. And also, we didn't have visuals to aid the descriptions of the regimen, so it was a little bit hard for caregivers to grasp what we meant when we said, oh, you could have this regimen versus this regimen versus this regimen. So in terms of next steps, I think we need to conduct interviews about preferences with inexperienced IPT users, any kind of PT users. And it would be interesting to explore providers' preferences regarding preventive treatment. But in general, I think that understanding patient preferences will enable us to operationalize the implementation of TB preventive treatment in high TB and HIV burden settings that are facing challenges with implementation in children. I think that's it. Yeah. Okay. Thanks.
Thank you so much. I think that was a great presentation and a perfect example of barriers related to treatment and also related to the recommendations we saw for shorter regimens. Does anyone have any questions for Yael?
We can also take questions at the end. Oh,
Okay, great.
On the chair.
Okay.
Yeah.
Okay.
So next up we have Courtney Yoon from Harvard Medical School, and she's going to be talking about challenges in ensuring preventive therapy for child contacts in Lima, Peru.
Okay. Thank you very much. Thank you for setting the stage for understanding the child contact management cascade. What I'm going to be talking about this afternoon is some experience from the field of trying to actually implement this cascade. And really, I just want to acknowledge that the people whose hard work on the ground that I have the privilege to report are actually the team at Socias en Salud, some of whom are sitting here, so I'm really presenting their work. I was somehow involved, but okay. So just by means of background, I just want to state the Peruvian preventive therapy guidelines for child contacts. So like many places, guidelines, in Peru, all household contacts of all TB patients are supposed to be evaluated for TB. And then after ruling out TB, 6 months of isoniazid is indicated for children who are under 5, but also children who are 5 to 19 years old who have a positive TST. So I want to point this out because often when we talk about child contacts getting IPT, people immediately think of children under 5 because this is a universal recommendation and it's something that we believe should be implementable in all settings. But it's worth just remembering that there are older children as well, and if a place has the capacity, we really should aspire to getting them access to IPT as well. So the setting for this work is Caraballo district in Peru. It's a peri-urban district in northern Lima. It has a population of about 250,000, of whom a quarter live in poverty, and it has a notified TB incidence of 100 per 100,000. And these photos show what I mean when I say peri-urban. So if you look in the valleys, which is kind of in the top part of the top photo, the valleys are quite urban. A street scene in the bottom photo shows you that it has paved roads, multi-story buildings, permanent structures, and this is where all the health facilities, the 9 public health facilities that serve this district, they're all located down in this easier to build in area. But the district is actually very hilly, and so as you go up the hills, you get these hillside shanty towns that the higher you go, the less infrastructure there is. So the photo on the top shows one of these hills. This one actually has a road, although it's not paved, but you can see that it has these small, more temporary structures, and some of the hills, in fact, don't even have these unpaved roads. So what this means is that there is a substantial physical barrier to contact management in the sense that the first step of getting the kids to the health center is actually difficult. So this photo actually shows how people make it down from the upper parts of the hills. If you see these yellow staircases, you basically have to walk down this series of staircases until you get to a road where you can get some sort of vehicle. And obviously, the higher up you live on the hills, the harder this is. But also keep in mind here, because of this barrier to really everything you would need to get to, the poorer you are, the higher up you live. A second structural barrier here is also the available of radiography and TST. So chest radiography is necessary to rule out TB, according to the diagnostic algorithm, and TST is required for making older children meet the eligibility requirements for IPT. X-ray machines and tuberculin are only available in the central health facility in this district. So if you're in one of the more peripheral areas, not only do you have to get down from the hill, but you also have to get into the center of the district. And then a final barrier, which has been characterized by colleagues previously, my colleagues and the colleagues from Socios, is that in this setting, there's actually very strong ambivalence among providers about IPT. Not only do they not think it's a priority, but there's a widespread misconception about it causing resistance. And in these in-depth qualitative interviews with healthcare providers, they basically said, yes, we know we're supposed to give it, the TB program is telling us all the time, but we don't want to do it. And so what I'm going to report on today is some efforts of a program called TB0 to try to overcome these barriers. TB0 was a program that sought to bring comprehensive and integrated care to TB patients and their families. It was a collaboration between Socios en Salud, which is an NGO, the Ministry of Health, and the municipal government of Carballo. And Socios en Salud, their role in this initiative was really to connect the health services with the community. Improving the management of child contacts was one component of this TB0 initiative, and it's the one that I'm going to describe today. So the first goal was to increase the evaluation of household contacts, because we know that a lot of them are not getting to the health facilities. So the strategies used by the Socios field team was to counsel TB patients and their families on the importance of evaluation, to offer to collect sputum in the community, particularly for working adults who were working during the hours where the health facilities were open, and they would bring the sputum back to the health facilities for testing, and to offer transportation vouchers for contacts, especially children, to be brought into the health facilities. And the second goal was to increase the use of preventive therapy. So for this, the team engaged providers. They actually posted the guidelines in the health facilities so that providers would be aware and remember. And they offered home-based directly observed therapy such that a trained community health worker would actually bring the IPT every day to the child's house, and the parents would not have to pick up the isonize it every 2 weeks, which is what would have to happen otherwise. And one of the reasons for offering home-based directly observed therapy in this context, it wasn't so much of a wanting to observe the children getting the therapy, but it was that this home-based DOT accompaniment model has been successfully used by Socios for the management of TB patients and is highly acceptable to TB patients in this community. So the idea would be that this would be analogous and would similarly provide benefits. So this is just an example of one of the communication materials that Socios made to try to communicate to parents the importance of treating TB infection in their children. So if you don't read Spanish, it says there are two stages of TB, latent TB infection, and active TB disease. And what this is showing is that in both cases, the bacteria is actually in the child's body. It's just in one case it's sleeping, and in the other case it's awake. To evaluate the impact of these efforts, we did medical chart reviews for all TB patients initiating treatment during 6-month baseline and intervention periods, and we collected data on the contact evaluation, IPT prescription, and the distribution of isoniazid from the standardized contact management forms that are held at the health facility. So one really nice thing about Peru is they actually have standardized contact rosters, management forms, medical evaluation forms that are put in the charts of all TB patients. So they really do have a system for collecting this information. And we were not involved in the filling in of those forms, so we were collecting information on what was happening in the health facilities. So you can see here that this is just to show that between the baseline and intervention period, the total number of TB patients and the number of contacts identified was roughly comparable. There's about 140 TB patients in each period. If you count contact enumeration as the first step of the contact investigation process, that means that the person's name is actually written on the roster in the TB patient's medical chart, then around 95% of patients were actually having that process completed. And among the contacts identified, around 40 in each period were under 5, and about 130 were in the older pediatric or older child age group. So the first thing, here's a feel-good slide in some ways. We did see improvement in the management of the young child contacts, those who are under 5 years old. So this shows the contact management cascade that Daria laid out in the first presentation, although has an extra step. So if you go along the bottom, you can see that the steps that have been broken out are the child's identified, the child's evaluated at the health facility, IPT is prescribed, and then IPT is initiated, and then IPT is completed. And this, what these bars show is the cumulative percentage of children who should have completed each step who in fact did. So the first thing I want to point out is that the good news is that if you look at the very last set of bars, the black bar, which represents the intervention period, is almost double the height of the gray bar, which represents the baseline period. So that is good. The bad news is that even with this doubling of the kids who actually made it to the end, it's still only 40% of the children who should have made it to the end. So that's bad. If you look at the percentage who actually complete each step, you can actually see where in this process things are starting to fall apart. So the first thing to note is that the proportion of children who were evaluated was greatly increased during the intervention period from 70% to 95%, which was a statistically significant increase. So what this told us is the strategy of counseling the parents and offering transportation vouchers actually was probably working. And the next thing to point out is that IPT prescription for children who were eligible for it is really the weak link in this chain. So in the baseline period, only 59% of eligible children were actually getting a prescription. In the intervention period, this increased to 68%, but this means that a third of children who should be getting IPT, they've had TB ruled out, and and their contacts of pulmonary TB cases, they're just not getting a prescription. In terms of initiation and completion rates, they were already actually fairly high compared to what's been reported from other settings, but there's still obviously room for improvement. So now I just want to switch gears to a less simple cascade, which is how do you manage the contacts who are 5 to 19 years old, these older children. So according to the Peruvian guidelines, they're eligible for IPT if they have a positive TST result. This makes sense. You're risk stratifying, so basically an older child who has evidence that they're infected should get the benefit of IPT. If you just try to put together the first part of this cascade, the identification and the evaluation, you see a similar trend to what you saw for the under 5s, where the intervention improved the proportion of children who were getting evaluated. But then if you ask, okay, well, how many of those who got evaluated actually got a TST performed? It was only 15% in the baseline period and 37% in the intervention period. And part of this was actually due to the global shortage of tuberculin, so there's clearly some factors that were out of anyone's control, but also keeping in mind the transport barriers, getting these kids to the health facility twice to get the TST read is a substantial ask for the parents. So this is my last slide of results, which is of quantitative results, which I just want to try to describe how is the TST being used. So the intention, obviously, of the TST is that you do a TST, and if the kid has a positive result, that means that they're infected, and so therefore they should be treated with IPT. If they have a negative TST result, it suggests that they're not infected, and therefore they don't need TST because they're not infected in the first place. So this graph actually shows the ending part, the last part of the cascade. So it starts with the person getting the TST result, and then goes to IPT prescription, initiation, and completion. The baseline period is shown on the left, the intervention period is shown on the right, and the vertical axis in this case is actually showing numbers of children, not percentages. So the first thing to notice is that the bars are higher on the right-hand side, which means that at least the intervention meant that more kids were getting through this cascade. But the question remains, okay, is the TST being used properly? The orange bars represent children who had a positive TST result. These kids should have gotten IPT, and they did, so that's good. But the green bars are the kids who had a negative TST result, so they should have been at the lowest risk because they have evidence that they're not even infected. They were also generally getting IPT. And if you look at the gray bars, who are the kids who didn't get a TST, these kids should be kind of in the middle risk-wise, because some of them are probably infected and others aren't. And it turns out some of them were getting IPT, some of them weren't. It wasn't very consistent. It wasn't like an age-related thing. It was just, I don't really know why. So just what I want to conclude from this is that it just seems like TST here is not being used effectively for risk stratification. So in terms of just summarizing the challenges that we encountered, among evaluated children who met the IBT eligibility criteria, the prescription was really the biggest problem in this cascade. So the prescription increased from 54% during the baseline period to 78% during the intervention period, but that still means that there's this 20%, 22% of kids who just aren't getting IBT, even though they meet the criteria. And this percent actually overestimates how well we're doing, because older children weren't getting TSTs in the first place, which meant that they didn't even have the opportunity to meet the eligibility criteria. So older children in this setting are really not getting optimal management. As it turned out, many providers didn't actually know that children over 5 years old were eligible for IBT. So that was actually the reason the team posted the guidelines in the health facilities. And then even once they became aware, barriers to tuberculin skin testing, it was just, this was just a hard thing to implement. One lesson that came out of this is really there's provider training that's needed. Providers in the primary care facilities were not comfortable ruling out TB in children, and this was really driving the low prescription rates in many cases. They're basically saying, well, I know we completed the medical evaluation and we wrote that they didn't have TB, but we're not really sure, and so if we don't give them IPT, at least we're not doing anything wrong. There's this perception that giving them IPT by mistake is really, really bad, so you might as well just not. Which I don't necessarily agree with, but that's just the feeling that's out there. And in terms of another area of training, as I mentioned, TST is not being used effectively for risk stratification. So one of the reasons that IPT was getting prescribed to children with negative TST results was because the providers thought, oh, well, if they have a negative TST result, that means they really don't have TB, so then it's safe for me to prescribe IPT, which is kind of missing the point of the TST. And then this inconsistency with children without a TST being prescribed, it's just not being used effectively right now. And then the final thing, the discussion is, well, what about our strategy to promote adherence? As it turned out, 42% of children initiating IPT had caregivers accept the directly observed therapy. The ones who did accept, 92% of them completed, so that's great. The ones who didn't accept, only 73% of them completed. And so what we learned from this is even if DOT works, home-based DOT for IPT in this setting is not as acceptable as it is for TB treatment. We're still kind of doing some qualitative work to figure out why that is, but in the meantime, we're kind of going back to the drawing board to think, okay, well, if this isn't the way to go, then how else can we promote adherence? So finally, the conclusions are that counseling and transportation vouchers were effective in our setting for promoting contact evaluation, that the prescription of IPT in this setting was the largest gap in the contact management cascade, and there's really challenges around effective use of the tuberculin skin test, and that capacity building for providers in primary care centers is required. Finally, I just want to acknowledge all the people who worked on this, many of whom are sitting here. Thank you very much.
Is it on? Thank you, Courtney, for this beautiful presentation. Does anybody have any questions for Courtney? Okay, I actually have a question if nobody. So I was just wondering, can you explain the difference between prescribing and initiating and how you knew?
Right. So prescribing, there's a standardized medical evaluation form in the chart, and at the end, the doctor has to write what the action to be taken is. So if they write IPT prescribed, then that's what we counted as prescription. Then there's a pharmacy pickup form that's also in that contact management card, which actually says if the parent started getting the pills. So that's what we counted as initiation.
That's great.
Yeah, Peru is a good. They actually have these forms, so it's awesome.
Thanks. Thank you very much. I was wondering if you could describe a little bit more in detail about how you developed the transport voucher system, whether you had any challenges with that, how it was, how the transport vouchers were provided to the healthcare clinics, and then how they were distributed to the families that needed them.
So the way that Socios and Salud operates in general is that they are a community-based organization. So they tend to operate in the communities to bring people into the health facilities, and rather than actually operating in the health facilities themselves. So the transport vouchers can just be given to the parents, at their homes. The community health worker who covers that family would be able to deliver it. I don't know the details exactly of how much money they were and how did they decide, but the team is actually sitting right here, and Anna, who has the blue shirt on, can probably answer your question after the session.
We gave close to $18 per month for every mothers.
Soles or dollars?
Dollars.
Okay.
200 soles.
You mentioned about very difficult to communicate with those healthcare providers to prescription and start treatment. I wonder if you can follow up for those children without treating, and those TST negative without happening with TB in the future, then feedback the data to those care providers, and they may be convinced by what we really want them to do, because we did it in Taiwan before. 10 years ago, they don't believe it, but after some data analysis and feedback to them, they kind of understanding that what happened in the United States or the other place will be the same in Taiwan.
Yeah,
so just
that's a good point. Just to use data.
Yeah.
Actually, so there was a very large cohort of contacts risk of disease progression study that was done in Peru, in Lima, has the results, showed the benefit of IPT. The national TB program, is totally on board. But the problem with the local health facilities is actually, I think, oh no, that was another session. Sorry. One of the issues with the providers in this area is a lot of them are basically these new medical school graduates who are assigned to the under-resourced regions that they have to do this period there, and then they just leave. So it's hard to maintain a knowledge base given the turnover.
Great. Thank you, Courtney. Next we have Hamida Hussain from Pakistan. She's going to tell us about child contact management in Pakistan. Where's the chair?
Okay. Hi, everybody. I'm going to talk about our experience in Pakistan of instituting a childhood TB program, which initially did verbal screening and then also did contact management and provided IPT. And then I'm going to switch gears from this project to another project and share a little bit of the preliminary data from another study, which is looking at INH versus rifapentine regimen. So just in terms of a little bit of the background, Pakistan reported a little over 300,000 cases in 2014, of which 9% were children. An inventory study carried out in the same area showed that about 27% of the cases are still being missed in Pakistan. And another story that was carried out in Karachi showed that in the majority of those cases are actually sitting in the private sector, because if you target those private sector, then you can actually increase the case detection by about 7 times, particularly for child TB. So the orange highlighted area, with this background information and knowledge, the orange highlighted area is the province of Sindh, and the red highlighted area is a district of Jamshoro, where we decided to set the study. And the aims and objectives of the study was to increase the capacity building of the healthcare professionals to diagnose childhood TB. We just heard that this is one of the major barriers. To identify 1,000 cases of child TB over a 12-month period, and then to increase access to diagnostics and treatment for child TB patients in an underserved population. The intervention, we're actually looking at mass screening at the outpatient clinics, and we chose public sector hospitals where the services were available, but patients are coming in. However, patients were not being diagnosed in these. So we deliberately chose public sector hospitals and set this up in a very programmatic settings. The second part of the program was to do contact evaluation for all the adults and the children that were diagnosed with TB during this time period. And the third was to do actually reverse contact tracing. The key activities that we carried out were training. So first, we trained the doctors who were present at that health facilities, and these were government doctors who were present at that facility and the health workers that were provided by the project. We established diagnostic network and referral network. So a microscopy lab were present at each of these facilities. However, gene expert facilities were available only at a fair distance away. So we established the networks that were required for transporting the sputum. We did provide incentives for the contact evaluation visit, and these incentives were about $5 per family, one time, one visit. And then we used technology to ensure our data collection was very up to date. In addition to which, we also connected the doctors in these remote settings to doctors in Karachi, which is the largest city in Pakistan, and at specialized centers. So using WhatsApp, Viber, Skype, whatever was available, they would call, the doctors from that area, that particular facility would call and talk to the clinicians present in the specialized centers. And the last, we ran a mass communication campaign, which included billboards, TV advertisements, which just informed the people what symptoms of TB and where to go and seek care. This slide just gives you a capture of our Android-based app, which was used for data collection, and these were smartphones. So now the results. So if you we set out, as I mentioned earlier, we set out to find about 1,000 cases of child TB. We ended up finding 1,700 cases of child TB. And because we were present at these facilities, we also did contact tracing, we also did screening and contact tracing for adults, and we found close to 700 adults with TB as well. In my rest of my slides, I'm only going to focus on the children, the data for children. So going back to the cascades which have been presented earlier, we screened about 100,000 children, of which we found 5,880 children who were presumptive, 1,400 were diagnosed with TB, and 1,404 were put on treatment. So we missed about 13 cases which we couldn't put on treatment. Age and gender distribution of those that were verbally screened, except for 0 to 4 years of age, where we see a preponderance of male, the rest were almost similar between male and female. Our presumed to screened ratio is about 5.6, very similar between ages of under 5 to 14 years of age, whereas the disease prevalence in this age group in this population was 1.3. Sputum positivity rate was only 7.9% because, as you know, children cannot produce sputum very easily, so we had very few BAC positive children. In terms of our outcome from this verbal screening, we had a 95% treatment completion rate, and that is very high. And part of it, the reason we believe is so high is because there was a counseling engagement that happened between the parents and the doctor, and they were counseled very well. At each visit, there was a counseling session that happened, so which helped the parents and empowered them to actually continue the treatment for their children. With these children who were identified and put on treatment, we actually then went back to their homes. We counseled them to bring the rest of the family for contact evaluation. If they brought the family, great. If they did not, we called them up. We requested them to come back again. And at the last resort, we actually went to their homes. So in total, we screened over 3,000 children. Of those, 1,836 were presumptive with TB. 1,600 were evaluated for TB, and 385 were diagnosed with TB and started on treatment. Again, our presumed to screened ratio in this population of the contacts was 61%, with a disease prevalence of 13%. So if we had not done the contact management, we would have missed all these cases. And the point to note is that those that were under 5, there's 18% disease that would have been fully missed if contact tracing was not part of this project. In this slide, the age and gender, we just see a preponderance of male children coming to the facilities rather than the females. And we believe that there is obviously a slight bias towards males being brought in for care rather than females. The treatment outcome of those contacts that were put on treatment, again, fairly high treatment success rate. We did not lose very many patients. They completed their treatment. The project had a very high disease identification rate, and we increased the case notification in this area by 249%. The project also put children on IPT, and about 304 contacts which had the disease ruled out were put on IPT. Only 51% completed treatment, 49% were lost to follow-up in this. And this goes to the point of isoniazid being 6 months long therapy, and parents not being able to complete the 6 months long therapy, at least in the setting that we have been working with. Keeping this particular aspect in mind, we had to design another project in an urban setting where we had to do contact management as well as provide preventive therapy. And looking at this data, we thought if we focus on INH for 6 months, we would probably get similar completion rates, and that may or may not be good. So we tried and we worked with our national TB program to actually help us and allow us to use rifapentine instead of INH. However, as we started that project, rifapentine was not available to us, and it was only midway into the project that rifapentine became available. So this slide actually is a combination of all the children that were given either INH or a rifapentine-based regimen. And we see that for 1,469 children were verbally screened for contact investigations. And of those, 1,000 were investigated, which is 74%, and we did lose a fair amount in the cascade between verbally screened and those that were investigated. We found one child with disease, and 1% of children with disease in this population, and then 73% were started on infection treatment, either with INH or with a rifapentine-based regimen. And of those, before they were started, 11 actually refused infection treatment, and the refusal rates is a combination between INH and rifapentine, and I'll give you the breakdown right here in this slide if you want to look through. So from all those that were started on infection treatment, 336 were started on infection treatment. 462 were started on INH and 336 were started on rifapentine-based regimen. The refusal rate for INH was 21%, whereas the refusal rate for a shorter regimen was 5%. Loss to follow-up was very high for rifapentine, whereas it was very small for 5% for 19% for INH and 5% for rifapentine. Treatment completion numbers are similar at this point, but at this point, this is an ongoing process and children are still being treated. On treatment, so currently we have 54% treatment, children on treatment with INH and 74% on 3HP. And we are slowly switching over from INH onto rifapentine-based regimen for the entire cohort. And this cohort is going to last till December, and then we will be able to provide the final results of what happened with each of these things. I want to acknowledge our project teams and donors. Some of my project team is also sitting here. Our Preventive TB Control Program, who were extremely supportive of this, and I can take any questions.
Thank you so much, Hamida, for that excellent presentation. Any questions?
Hi, thank you, that was great.
Did I do something wrong? No.
Thanks. That was great, thank you very much. I was particularly intrigued by your human resource capacity building of linking a TB expert to the cases. But, you know, it's very quick as you went by. So I did a quick, and I think you said that all cases were reviewed with a TB expert before starting treatment. I didn't know if you meant all cases were offered that link or all cases did have that link, because when I did the back of the envelope calculation, it was probably at least 100 cases a month during your period. So I was just thinking that's a substantial amount of resource time. And so also I was just going to ask about if that's true sustainability or thinking about things like Project ECHO to link multiple people together at once. I just thought that was a fascinating part of it all.
So what we did is we did the training for all the doctors that were present at the individual facilities initially, and made them comfortable enough to treat and identify children with TB or then put them on IPT. The connection with the specialist was for difficult cases or when the doctor was completely unable to make a judgment call. So they would immediately then connect with the specialist. So the idea was that if a patient is sitting in front of you, they should not go back because the doctor is unaware or is uncomfortable making a decision. They have help, which they can immediately get a second opinion, and the patient who has come in front of you immediately gets the treatment that is required for that.
I may have missed, did you check every child that walked into that clinic, or were they children that were complaining, or they just happened to accompany an adult? How did they arrive?
The verbal screening?
Yeah.
So these were pediatric outpatient clinics. The child may have come for any reason at all. They were all screened for TB.
Any other questions? Great, thank you so much, Hamida. So thank you all for coming. I won't keep you from dinner much longer. But I hope that we can all agree that it's time to move beyond IPT initiation and really start to think about the entire child contact management cascade. And you know, we saw from Courtney that in fact it's probably not just 4 steps. There are probably going to be many steps added, and we've seen that happen with the HIV care cascade as well. And so I think as we continue to implement child contact management, we're going to continue to discover more and more barriers that we will need to tackle. I think we saw from Hamida a tremendous effort on how to operationalize CCM and how difficult this can be in low resource settings. And finally, I think Yael shed light on the importance of a patient-centered approach to decision making that is really key to our NTB strategy. So I will leave us all with that. Thank you so much.